We're going to talk about everybody loves glaucoma before lunch. It's everybody's favorite topic. We're going to talk about changing your mindset and how we treat this. I like glaucoma. I know it's weird, but I do. It's a great opportunity to pray with people because they're scared. So, how many times we get asked to pray with somebody and I got 25 more patients in the morning to do, but I always take the chance to pray with them right now. Just hold out your hand and pray with them right now. So, great witness to them. It's also a great witness if you have a non-believing staff member scribing for you. They get to listen to you pray over and over and over again, which is good. So, we're going to go on with treating glaucoma and how do we change it, because traditionally it's just been, here, let's throw all these drops at you. Okay, well, that we're going to kind of go at how we do it. And by the way, breaking news: Mattel has come out with Blind Barbie now. So it has a little walking stick with the red and white things, and acceptance of that. So here we go. And maybe. There we go. My disclosures: I do speak for Allergan and Sight Science. Make sure it's turned on. Did you turn it off, Andy? It says turned on. Boom. There we go. Question number 1. Do you actually believe your patients use the drops as you tell them to? Seriously. I think we may say that we don't believe them, but we practice as if we do. The drops are good. Simbrins is good. Combigan, Lumigan, all that stuff. It's good, but they're not using them. You might see the study. It was when I was in residency a long time ago. How many times the patient who's just on one prostaglandin a month actually uses? How many days? The patients who actually report, they tell you they use them. How many times a month do they actually use them? It's an old study. 18 out of 30 days in a month they actually use them. So very little. So some of us practice medicine like we're these guys. It's kind of old school to just throw drops continually at people because they don't use them. So don't be afraid to change how you practice, which if you've been in practice for a long time, it's hard to think in the lane how to do it differently. But I trust myself more than I trust the patients. I know what I do is going to work, and I don't trust them to use their drops. So there's so many options now. SLT, MIGS. I don't do blebs. Don't like blebs. So if you don't like blebs, there's still a lot of options you can do. I try to SLT everybody. That's a great one. So we're going to go through these. First of all these eye stents. Okay, eye stent. It was nice when it came out. It's just, okay. I use it every now and then to patients that are mild. I know Derek doesn't like to put things in the eye. We've had that conversation many times. Sometimes I heard from the podium, maybe one of these meetings 5 or 6 years ago, I heard Dick Lindstrom say, if you have a patient that has a cataract and they have glaucoma and you don't give them a MIGS, you're not up to standard of care. I don't know if I agree with that completely, but I do eye stent in these patients that are very, very mild. Sometimes they work, sometimes they don't. Keys, you want to try to find the darkest pigmented area and put it there and spread them out. You don't want to indent too much when you put them in there. You can shoot it through the meshwork. I saw that movie a couple times. The annoying part of eye stents is if it fails to seed and then it's floating around in the anterior chamber and you got to grab it again and then you're going, ah. So basically take it and push it up against the meshwork. You have to do it in conjunction with phaco, except you have the new infinite. First I did one, and then we did the other one that you drug it across, then you had the one with a gun, now you have 2, now you have 3. There's more chance for it to fall out, so I don't do this too much. I almost want to have an eye stent Uzi that you just kind of come in like a rapid fire across there to get them to all go. But I actually, since this, I did my first streamline Monday, the canaloplasty to try to make that work. I don't know how it's going to work. It was pretty easy to do. I'm going to switch out probably streamline for eye stent. It's kind of the new plan. We were in the Hydra study. It worked pretty good. It was better if you could do a little canaloplasty first because it would go right in, but now the insurance doesn't like you to do that. So in our study, we had to see them all at 12 years in gonium, had to submit it. And it really kind of weirded me out when you had both ends of the eye stent, of the hydrus hanging out in the eye. And the patients didn't notice it, but it really bothered me. And so I was like, what is the world? Well, apparently that's in patients who have really long action length and high white to whites, and it doesn't affect the result. But I don't do this too much because it just irritates me when I get them half in and I have to sit there and push on them for 5 minutes, and they don't really, but they work great. You can use a Sinski or Tianto to come in and like perforate the meshwork, and it'll go in easier, is the new trick I've been told. You have to go in through you have to make the extra incision through the side port, and again, you have to use it in conjunction with phaco. All right, so what do I do a lot of? Well, in our clinic, got two of my great partners over there. We do a lot of the implantable Bimatoprost. Durista is the name brand Bimatoprost, as opposed to iDose has come out. Has anybody done iDose? Anybody heard of iDose? iDose is from Glaucoma. It's the implantable travoprost. We are not going to do this one. iDose costs anywhere from $13,000 to $15,000 for 3 years of travoprost. It just seems to be too much of a burden on the system. We're not going to do that one. And I like travoprost anyway. I had 5 patients, pressures go up 6 points when I put them on travoprost, so I stay away from that stuff. I think it's trash. But when you do Durista, or Bimatoprost as we'll call it, you get the name brand. And so who's a good patient? So you want to find somebody who has open angle. Anybody who wants to reduce how much they pay for medicines, because if they have Medicare to supplement, it's free. I like free. You're basically going to take them off their prostaglandin. You don't want to do somebody who's been prostaglandin naive. So our referring optometrist, we tell them if they have a patient that they're diagnosed with glaucoma, they want me to do the Bimatoprost implant, then they need to put them on the latanoprost before they send them to me. It's equal to 1 med, you'll stop that. Patients who have dementia, Parkinson's, anybody who forgets to use their drops, which is everybody, but especially the men. Y'all find the men are worse at using the drops than the ladies are? Like, especially with prostaglandin, the ladies usually wash their face at night, or I tell the men do it when they brush their teeth, but the ladies are better. Men fall asleep watching football on the couch. Like now we have Thursday night football, NFL. You can watch Friday night college, Saturday night college, Sunday and Monday NFL. Men aren't using it very much because they fall asleep all the time. I just assume they're not using it, and just you need to make it non-threatening to the patients. Like, listen, I know you're not using the things every night. How many nights are you actually getting them in? Like, I know you're not. And they laugh at you and look at it. You know, patients with dry eye, we're going to talk about that a little bit. I got some pictures of one of my favorite patients. Patients that are busy. How about adult patients? Senior adult patients with adult children who have to drive over to their house every night to put their drops in. It's a big deal to get rid of for them. Basically, it's anybody who has glaucoma is a candidate as long as they meet a couple of inclusion criteria. But think about it. It's a mindset change to think about it. When they come in, they're on the drop, their eyes are red, a little bit. We're all used to tolerating that little bit of redness. Okay, the patients are taking holidays from their drops before they have pictures, family reunion. They just to feel better. So this is a way we can help them. It's less money, better on the corneas, less red eyes. You can do it before or after SLT. New patient comes in, they're on 1 or 2 medicines. I don't mind taking them from 3 medicines to 2 or 2 medicines to 1, but we'll do SLT. You can do it before SLT, after SLT, but patient comes in there, they're on, let's say, brimonidine, latanoprost. You say, hey, let's SLT you. We'll come back in a month, take a look at it, pull you off the brimonidine, see how you're doing. That's usually equivalent to 1, and then we'll give you an implant, take you off the prostaglandin. Now you have nothing. You know who in our clinic loves the implants the most? Adrian is right there. She says that anybody that's on a medicine is a candidate for the implant, especially in January. So what do y'all think Adrian does for us? Anybody know? Prior authorizations. So I have to pay her to sit. She's one of our glaucoma techs. I pay her to sit 1 full clinic day a week and do PAs, which she loathes. But she has to do them. Somebody has to do them. And so she does it. So anytime we can reduce the number of patients needing their prior authorizations, especially in January, she can spend more time on the floor. She's happier. Patients are happier. It looks good. So who is not a good candidate? Anybody with a bad cornea or Fuchs, history of CME? I think I'm missing 1 actual prostaglandin allergy in my career. It's not common. So you're talking about like they have to like really be itching. Derek, you see a lot of them? No, I don't think so. Me neither. So if you give them a trial and they have red eye, it doesn't mean they're not a candidate. It means they're a good candidate. If you give them a trial and their eye wants to itch off, then they're not a good candidate. All right, what to know. Now, this is my little pearl. We seem to be the only clinic around that has this issue. But we've been doing these since 2020, July. Chip did the first one in South Carolina. And that patient's still going strong, doing great. So the medicine is supposed to last 4 months. I tell my patients this is 6 to 12 months, most likely. In our clinic, over 3/4 are still going at a year. So it lasts a long time. We've got patients like that guy going 4 years, still going from the first one. Okay? In our experience, we go back to that one. Did I hit the button? Thank you. In our experience, like I was mentioning before, in black females, they have a risk of trabeculitis and their pressure going up in the week afterwards. Nobody else seems to have this problem, but apparently in Columbia, South Carolina, the black females can have a risk for this. If you know in your cataracts, they've got a much higher risk of rebound inflammation. So it translates. So if you put them on Prolensa BID for a week, you won't have the problem. We had it 3 times, did it, not an issue. Not the males, not white females, just black females. So that's a little pearl. Do that and you'll be happy. Talking to patients about it. Don't use the word injection. They think you're going to have a needle like this big, okay? I can place an implant in your eye. It's an insertion, or I can insert it, okay? Like I said, it'll last 6 to 12 months. Would you like to go 6 to 12 months without using that drop? How much does it cost you? You know, if it's $10 a month, that's not a big deal for me, but for a lot of our patients, that is. Even if it's generic. If you can save them, how would you like to save $120? It's a big deal for a lot of these people. So it gives you 10 micrograms. The injectors 28 gauge. Don't say the word needle, please. If asked, very few people ask how they're going to get in there. If they do say I have a clicker, I can place it in your eye. Because I always say the purpose of language is to, accurately describe what we're going to do. It takes 10 seconds. There's 0 pain. They actually timed me a couple years ago without telling me. I was in and out of the room in 1 minute and 57 seconds. And the patients is 10 seconds, no pain. Little old ladies love it. Who's the most chicken to get it? Middle-aged white guys. I don't know why, but I just tell them little old grannies do fine with it, and I try to appeal to their manhood, and they do great. Get your staff involved. It's best when, if the tech, we did a contest. We actually gave away gift cards to someone. You remember where we gave gift cards to? Me neither. I don't know. The tech who had the most, they have to convert them. They just have to have the conversation with them. As they're entering stuff in EMR, would you like to do something to get off some of those drops? All right, well, Dr. Platt will talk to you about that when he sees you. Boom, we have something you could do. So they like it, they own it, and then they get excited when the patients are still working. How to insert it in there. Okay, so we've talked to them. They're going to do it. We like to sign them up the same day before they leave, because the longer they go, the bigger that needle in their mind gets, and they get scared. So we're going to take care of it. Most people do it at the slit lamp. We do it in the minor treatment room supine, because I like to take a little cut Wexel and use it as a countertraction. If a patient I did one on the slit lamp the other day, because the guy had some dementia and he was struggling to get around, and I'd already been in the room talking to him for about 15 minutes, and we just went, and it went fine. But if you do it supine, you get the countertraction. That's how we like it. So I actually will go in between patients and just go down there to get them set up. You want to make your tunnel flat and give it some length. Okay, if you make your tunnel at an angle, you're going to have some problems. Make it flat. It's trained to do, they say 2 bevel lengths. I go 3. I've never had one come out. You want to aim towards 6 o'clock in the eye, and it will drop down there. Once you press the button, now you have to press that button with some authority. If you just kind of, the implant will just kind of come out and it'll stick to your tip. So it does that anyway sometimes, but hit it with some authority and then count 1001. And sometimes it shoots out like a missile. Sometimes it kind of comes there and just kind of sits. Jiggle it a little bit, and then when you're removing it, you don't want to pull up as you come out, because you'll burp the wound and fluid will come out, and it'll be over there and it'll shoot right to your incision. I'll show you a little movie about that coming up. All right, so this is Paul Singh doing one. He does it supine like we do. So he goes in 2 bevel lengths. Now you notice he doesn't use a speculum. We do. That's a duller one right there because it took him a little bit to get in. It pops out, sits right there, aim towards 6 o'clock. I always use a speculum because Avastin came out when I was in residency, and I can hear Robert Rosa like in my ear going, "Don't let the needle touch the lashes or you're going to get endophthalmitis." So we use a speculum on everybody. If they complain about anything, it's the speculum. But I think it's safer because that's what Dr. Rosa said, so that's what I do. All right, possible issues. Everybody likes to talk about how it's easy. What do you do if there's an issue? Okay, what if it sticks to the insertion site? It doesn't matter, just leave it. Okay, it used to bother me, so I'd have them march down the hall. Like I tell them, we have a bowling alley office, those real long hallways, all the doors are off it. So you'd see some of my patients like, stomping down the hallway and bouncing their feet, and the vibrations knock it off, and then you can feel better about yourself when you see it floating down at the bottom. That's the little trick. If it's lodged in the insertion site, I've never seen it. It doesn't matter. It doesn't cause a problem. Benjamin was at his drum lesson one time, and I couldn't hear, so they called me from a doctor southern South Carolina that had one lodged in the tract, and it was a Friday afternoon. They didn't know what to do, and I didn't hear the phone, so I didn't call them back. And they'd already went home. They left it in until Monday. No edema. It was fine. If it falls behind the pupil, it doesn't matter. It'll come out. Actually, now I watched a video last month from my friend Nate Ratcliffe. He was doing a reimplantation, and he was putting it behind the pupil on purpose, so it doesn't cause a problem. You can go back there. I used to do them at the time of cataract surgery, but in our state, they don't encourage you to do that anymore. So here you go with first one with it adheres to the tip. Let's see if that'll play. Maybe. There you go. I got 2 videos going now. The one on the left is going to adhere to the tip. The one on the right, or I guess in the middle, it's lodged in the tract. And then you can take it out. We can skip through that one. I had to take one out. It caused some corneal, for some reason, put them in both eyes. You remember residency? Like if you ever said, "Hey, Eddie, this is the nicest patient you've ever seen. What's his diagnosis?" Cancer, right? That guy always says, like, "This is my nicest patient, Mr. Bagnell." Like, put him in both eyes. Like, one eye had some swelling. So we've done, I think in our clinic, around 650 of them, and that's my one guy with some swelling. There's another doctor in Columbia that had one, so I know of 2 cases. Took it out and got better. But if you have to take it out, it's very, very simple. Just rinse it out. Let's see. Can you advance me to the next one if it's not rolling? We're watching that movie again. Boop. There you go. All right. We'll go back one. There we go. So, there you go. So, my partner Brian, when it first came out, he was worried we were going to have Frosty the Snowman down at the bottom of the eye. They dissolve. Most of them look like the bottom when they turn into these little balls and they kind of go away. Sometimes they stay cylindrical like that, but you're not going to have a big... The patient can't see it. That's the main thing. You're not going to have a big snowman down there. All right. So it is on label for single use. We do off-label stuff all the time. I just tell the patients if it wears off, they all want a new one. So I tell them, hey, it's off-label. You can have it. It's been covered. Medicare and a supplement is free, and it's been recovered. A couple patients I've done 3 in. Most patients, I said, are still going on their first one. Again, you can do it posterior to the iris. Off-label stuff, I just tell them we do it all the time. Like when I used to do pterygiums, I put Avastin in the pterygiums beforehand, and they would shrink by like 50%. I actually had to cancel one guy day of because the pterygium was gone. So it was off-label, and patients they're very cool with it as long as you explain it. Do all your counseling. All right. So here's a couple people. Guy on the right, by the way, when we're having prayer for tomorrow, that's Carl. He's one of my favorite patients. He has prostate cancer metastatic to the bones right now. So if you'll pray for him. He came in. He has had 2. After his first eye, he came in, and that's back in 2021. We did his first one. You can tell from the mask. He came in and he says, "Doc," he always calls me Doc. He was on Lumigan, Combigan. He goes, my wife says my eyes are too red. Okay. Did it, came in. His lasted a year. Came in again. "Doc, my wife says I can't have my eyes looking like tomatoes anymore. I need one of them Duristors. And I was like, and he's an elegant guy, but he just put an R on the both of them. It was pretty funny. So did it again. He's great, doing super. The lady on the bottom right, she was our 100th patient. She's very, she got a great personality, but I like her. Any 80s pop music fans in here? Her name is Betty Davis. Yes, I take care of Betty Davis' eyes. And she's great. And then the gentleman on the top, that's Bishop Jerry Kula from Liberia. He comes up to Columbia for me to take care of his glaucoma. Cool guy. He's cooking with just SLT, so not everybody gets this. Here's a case of, this is one of my, she's tremendously nice patient. She's 80-year-old female. She's had 10 years of pseudoexfoliative glaucoma. And she'd been running 12 to 14 just on dorzolamide timolol. She has pseudophakic. She had an eye stent in the first eye a long time ago. There's her cups. She had SLT, and she has had 2 implantable omatoprost on those dates. And she's just chilling at 14 to 18, rocking along. So she comes in on November of 2022, and her pressure is 40. There's no inflammation. So I gave her brimonidine and, okay, it's Rocklatan. I can't even say that word. Nothing. Whatever I did, I could not get her pressure under 40. What do? This is a surgical glaucoma patient, okay? Don't like blebs. Don't like blebs. So what are we going to do next? So I gave her an Omni, and her pressure was 4 the next day, and her wound was not leaking. Settled in at 14 to 16 just on the dorzolamide timolol. I can tell you when I did I'll show you, and let's go one more on hers. So on Omni you get canaloplasty and goniotomy. So I did a 360-degree canaloplasty on her and a 90-degree goniotomy. So I went in to the right, injected the blue tube. When I pulled it back, it leaves viscoelastic. Turned it, did it again for 360, and then I put the tube back in for a third time and did a 90-degree goniotomy. When I did her canaloplasty, I had to really push. It comes on a little device. I had to push the lever. I really had to push. And she was moaning while I was doing it for pressure. Her canal was collapsed. And that's what happened. It just opened up her canal. You know, an Omni gets you at the meshwork, the canal, and the collector channels. So it worked great. You can do Omni standalone. You can do it in conjunction with cataract surgery. I did hers standalone, and she's doing great. So she's still doing great 2 years later. So this is one for these patients where a lot of times, you know, the company really likes you to push. You can do it for mild patients. Our clinic is moderate and severe. You know, in our area, we have 30 to 35% patients of African descent, and so you get those patients and they need some kind of bleb surgery, and there's one bleb surgeon in our area, and you need a letter from the governor to get in to see him. I mean, just the way it is, he's so busy. And so they need to drive somewhere to Aiken, which is about 45 minutes away, and these patients who need a bleb, most of them don't have a ride. So what do you do for them? An Omni's a great option, and so it gets the pressure down. It's pretty simple. That's what it looks like as it comes in. The newer data that this just came out in June is that they did the 36-month studies on the Omni patients. We're going to roll through this as we come. That the pressure reduction was maintained at 3 years, so with 1.3 medications reduced. That's what you're looking at. You're looking at the longevity. 90% of patients got off at least one medicine, and that's the continuation of that one. So Omni, the trick, as you come in, you want to come in a little bit angled and throw that little blue injector out, and it finds its canal fairly simply. And if it's not there, pull it back, scooch over a little bit, and send it in there again. And with the goniotomy, you can do 180. I do 90 because I like to operate where I can see. Just pull that prism off and go 90, and then pull it out. I had seen a movie where somebody gave a little iridodialysis right underneath the incision because he did a 180 goniotomy, so that made me stop. But those are my guys. They're back there in the back right there. My triplets. Somebody else has triplets here. Somebody else has triplets. Yeah. Oh, all right. Yeah, we will chat after this. And my bride, and then my partners. So, thanks, guys. Yeah. No.
Gene's going to go out and let him ask it because we can't hear anything. Tell him that.
Got it. If you have a question, Jeannie's going to come out and let you ask it in the mic so that whoever's listening online can hear. Well, there may not be any. Thanks, brother. Here we go. There we go.
Quick question. On the Durista, if you go a second time, I heard you say it's off-label. Are you having any problems with Medicare and supplemental paying for the second time?
Zero.
Really? Okay.
Zero. Now, we have not done a re-implantation, as we call it with the patients. We have not done a re-implantation on a commercial or a Med Advantage. Commercial, there's a nice rebate program where they'll give you, like, basically buy one, get one free or something like that. So the insurance handles that. But Med Advantage is the one that can be a little tricky sometimes. But what it is great now is that if I'm in the room with someone, I don't want to, like, get off track. So if I'm in the room and I look at it and if it's Medicare and a supplement, fine. If I'm not sure, I just pull it out and text the insurance department and say, hey, chart this, reimplantation ? And they send it right back, and it's easy. Instead, I used to have to send my scribe down there, but now we just text them.